This is RX Knowledge and my name is Tahir Malik. Hi guys, how are you? Hope you're all fine. So before coming on to the main topic, I would like to tell you some things about this channel. The first is the main purpose of this channel is to spread as much knowledge as I can about the pharmacology and clinical subjects that are very vital in different international exams like KAPS for Australia. There is a pharmacy exam for Ireland, and PEBC for Canada, and Naplex and FPGEE for US. Many of the aspirants want to appear in those exams, but they want to do it in and they want to do the preparation in less time. So for those of people, I have prepared some of the notes that can help you in some way or another to prepare for the exam in less time, and I'm here to help you guys through this because I know it takes a lot of time and effort to put notes in one page or two pages, or to do or make a summary out of this. So it's a difficult task and it takes time. So I try to come up with those summaries or notes that can help you prepare in less time. So without wasting time, let's go on to our topic. So our today's topic is cholinergic agonists. So first of all, I would like to tell you that in all of those exams, the common thing that come up, or the major subject that come up, is pharmacology and the clinical. So if these are on your tips, you would probably pass the exam. So these should be on your fingertips. So the first topic that I chose is cholinergic agonists. So I have taken sources from Lippincott, CPR, and different other books, so you can consult with them too. So I have gathered notes from many books and try to summarize those. So the most important thing in pharmacology is classification. Yes, you had heard that right. So when I started for preparation, I thought that classification is not important at all, but it is actually important, guys. The most important. So for this, you have to buy some classification chart and put it on your wall and paste it there, and every day you have to see that wall and the chart, and you have to try for one classification every day, and I think you will be able to prepare for it in 15 or 20 days max. So I have some classification chart that I would like to share with you guys. As our topic is cholinergic agonists, I'm sorry, yeah, let me focus this. Sorry guys, I'm new. Yeah, this is cholinergic agonist. So this is classification of cholinergic agonists. So this type of chart you must have this type of chart in order to memorize these classifications. So as our first topic is cholinergic agonists, you can take the screenshot of this if you want. So these are the cholinergic agonist classification. You can see it later. So we will be going to our main topic now. Pardon me guys. So let me focus this. So coming on to our main topic, that is cholinergic agonists. So there are basically four subclassifications. The first one is direct acting cholinergic agonist. The second one is indirect acting cholinergic agonist, that is reversible. And the third one is indirect acting cholinergic agonists that are irreversible. And the last one is reactivation of cholinesterase. So first one is direct acting cholinergic. So as the name shows, it directly binds to acetylcholine. The drugs that are included in these are, the first one is acetylcholine. So when it comes to mechanism of action, acetylcholine decreases the heart rate, decreases the cardiac output, decreases the blood pressure, increases salivary secretions, increase gastric acidity, stimulate intestinal secretions and motility, it also causes bronchoconstriction. This is very important. And it also increases the tone of detrusor muscle, that is, it causes urination. And it also causes constriction of pupil, that is meiosis. And important thing is it is used in surgeries mostly. So the next is bethanigol. Mechanism of action includes increase in intestinal motility, that is, it causes diarrhea, and it also stimulates urination. So mechanism of stimulation of urination is it causes stimulation of detrusor muscles and relaxation of sphincter muscles. So when it comes to treatment that is related to bethanigol, the first is it is used to treat neurogenic atony, and the next is megacolon. So neurogenic atony is basically bladder condition that is related to brain or spinal cord, and megacolon is basically abnormal dilation of the colon. So the next compound is carbachol. So in carbachol, the mechanism of action is it releases epinephrine from medulla, and it causes meiosis, and also it causes spasm of ciliary muscles of eye, that is, it maintains the eye in constant position. When it comes to treatment, carbachol is used to treat glaucoma. So next we have is methacholine. So methacholine is basically used for bronchoconstriction properties, and it also diagnoses asthma. That is very important. Methacholine diagnoses asthma. So next we have pilocarpine. So pilocarpine causes meiosis. It also causes spasm of ciliary muscles. It causes secretion. It causes fat secretion, and also secretion of tears, and also saliva. When it comes to treatment, it is used for the treatment of mydriasis. So meiosis is basically constriction, and mydriasis is basically dilation of the pupils of the eye. So it also used to treat xerostomia, that is, it provides salivation. So this is basically an important information, that is pilocarpine plus Fimeline is used orally for the treatment of Sjögren syndrome. In Sjögren syndrome, there is like dry mouth and lack of tears. The next subclassification is indirect acting cholinergic agonists that are reversible. Reversible meaning they bind reversibly to acetylcholine. First drug that we will be discussing is adrophonium. The most important thing is it diagnoses myasthenia gravis. Adrophonium diagnoses myasthenia gravis. It actually differentiates between cholinergic and myasthenia crisis. So myasthenia gravis is basically weakening of the voluntary muscles, and in cholinergic crisis there are a series of symptoms like paralysis of the muscles, and also seizures and respiratory failures, and ultimately in some cases death. So it will differentiate between myasthenia crisis and cholinergic crisis. It also reverses the neuromuscular blockers effects. Remember, adrophonium basically reverses the neuromuscular blockers effects. The next one is neostigmine. So it basically manages the symptoms of myasthenia gravis, and is also used as an antidote for neuromuscular blockers. There are some side effects of neostigmine, that is, it causes flushing, salivation, and decrease in blood pressure. There is an important information about neostigmine, that is, it should not be given in urinary bladder or intestinal obstruction. That is the key to remember, guys. This is the key. This is the key information. So next is physiostigmine. So physiostigmine basically form carbamylides when it interacts with the enzymes. When it comes to treatment of physiostigmine, it is used in the treatment of overdose of atropine. This is very important. Physiostigmine used in the treatment of overdose of atropine. And next is it also reverses the neuromuscular blockers effects. When it comes to side effects, physiostigmine causes convulsions and bradycardia, decrease in cardiac output, and it causes paralysis of skeletal muscles. Remember, guys, what causes the paralysis of skeletal muscles? Physiostigmine. So the next one is pyridostigmine. So when it comes to treatment, pyridostigmine is used for the treatment of chronic management of myasthenia gravis. So when there is a question that what drug is used for the chronic management of myasthenia gravis, you should know that it is pyridostigmine. So next, the drugs that are included in indirect cholinergic agonist reversible are that are left donepezil, glantamine, and rivastigmine. These are basically used in treatment of loss of cognitive functions in Alzheimer's disease. That is very important information, guys. So write it down somewhere. So the next classification that we'll be discussing is indirect acting cholinergic that are irreversible. As the name shows, it irreversibly binds to acetylcholine via phosphate groups. So the drug that is included is ectothiophate. So ectothiophate is basically not used clinically. Ectothiophate has no benefits as such. Rather, it has some harmful effects. It is actually an organophosphate. It is harmful to the body and sometimes poisonous too. So atropine, the important information is atropine can reverse the ectothiophate overdose or dose, as a matter of fact. The last classification is reactivation of cholinesterase. So it is basically a antidote for organophosphates. So the drug that is included in this is pralidoxime that reverses the muscarinic and nicotinic effects of organophosphates. That the organophosphate actually we have discussed is ectothiophate. So the major information that you should know is it does not reverse the toxicity of acetylcholinesterase inhibitors like physiostigmine, pyridostigmine, and neostigmine. So pralidoxime only reverses the muscarinic and nicotinic effects of organophosphates, and it does not benefit in CNS effects, or it does not reverse the toxicity of acetylcholinesterase inhibitors like physiostigmine, rivastigmine, pyridostigmine, and all. So that is all from me. So guys, I would like to tell you some things that you should know, the thick information in this that I have discussed, like methacholine diagnose asthma, you should know for sure, and you should know what is the drug of choice when it comes to glaucoma. That is, it is pilocarpine. So these are some of the thick information that you should know in order to pass any competitive exam, and inshallah you are doing well and you will get through this. So that's all from me. Thank you very much.